Okay, good morning, everyone. I think we'll try to commit to starting on time because many people have to jump between sessions. I'm very pleased to be joined by my co-chair, Dr. Paisan, and I hope that we'll be joined by our other co-chair, Dr. Rajendran, soon, but not sure exactly when. But in any event, we will move on. We have a few people, speakers who are going to be joining us by virtual recording as well. But one of them is also online, so we'll be able to take questions. So with that, maybe I'll turn it over to Paisan to introduce our first speaker.
Thank you, Bas. Well, it's my pleasure and honor to share this session with Bas. So the first speaker, without further ado, may I ask Professor Bas Sada to talk about imaging Duchenne, geographic atrophy, and neovascular AMD. Please, Bas.
Thanks, Paisan. If I can get my talk up, or do I have to do that? Okay, fantastic. So yeah, I have a tall order to cover in 10 minutes, so I'm going to talk specifically about geographic atrophy, neovascular AMD, and not say a whole lot about drusen, just because of the limitations of time. These are my disclosures. So let me first start with how we approach the diagnosis of geographic atrophy in 2025. A few years ago, we actually had published this report summarizing some of the advantages and disadvantages. This is not meant for reading. I just wanted to throw the reference there if someone's interested. But just want to also highlight here that flash color photography has been the gold standard for diagnosis for many decades. We have this very nice definition for atrophy in looking for sharply demarcated borders of depigmentation with increased visibility of choroidal vessels. The challenge, of course, with standard flash color photographs is that in the real world, we don't always have sufficient contrast to be able to identify the borders of atrophy. We all can tell there's atrophy in these images, but exactly where does it begin and end is really a challenge. And that's where we're fortunate that we have improvements in imaging technology in the form of confocal imaging, and then on top of that, multicolor imaging, as I'll mention. And we have shown that with confocal imaging, we can improve the contrast for identifying the borders of atrophy and actually achieve reproducibility amongst human graders, at least, for comparable to fundus autofluorescence. Now, of course, you can use white light through a confocal aperture, but of course, you can use different component wavelengths of the spectrum to require this kind of imaging. And again, this kind of confocal multicolor imaging can do very well for rendering atrophy. And of course, when you're using multiple individual lasers, you're not restricted to using RGB, and you can use infrared light as well. That certainly is deeper penetrating, can be really useful for identification of atrophy. It does look kind of strange, but again, you get very nice demarcation of the atrophy with better reproducibility for its identification. So fundus autofluorescence, though, I think has really become the recent standard in clinical trials, and it's not hard to see why, because of that same case I showed earlier, where the atrophy borders may be difficult to discern, but are very readily identified as areas of decreased autofluorescence on the fundus autofluorescence imaging. And of course, this is not surprising that this has become a key outcome measure in many clinical trials. Now, there are some potential limitations of blue light autofluorescence. It can be quite uncomfortable for those of you who've been imaged with this technique. And some have questioned, even though we have ANSI standards for this technology, whether in the setting of retinal disease, whether those patients may be more susceptible to repeated blue light exposure. Fortunately, many devices now offer the option of green light autofluorescence, and this nice paper from Frank Holtz's group had highlighted how they can achieve similar measurements as you obtain with blue light autofluorescence. And more recently, we evaluated this on using ultra-wide field imaging platforms, and we demonstrated that graders can do this assessment quite reliably, although, and then the measurements are quite well correlated with standard 30-degree imaging, although I will say that they don't exactly measure the same, and don't have the time to get into the details of that. You could also use near-infrared reflectance imaging to measure atrophy. We've shown that that can also be quite reliable, and this may give us maybe useful because many of our historical OCT data sets also have a companion IR image that potentially could be used for this type of assessment. What about OCT? Well, atrophy can readily be identified on OCT. We can all see these areas where you see increased transmission of light into the choroid, and we take advantage of that signal we call hypertransmission. When we do an en-face projection image of the OCT data, it appears hyper-reflective on the en-face image. We and others have shown that this correlates quite nicely, measurements of that area of hypertransmission with OCT. But there questions came up with regards to, well, what is a threshold at which you call this hypertransmission atrophy? And it turned out we really didn't have a consensus for this definition, and so that was the underpinnings for the CAM program. Some of the CAM authors are here in the audience, but atrophy ultimately in this consensus discussion was identified as an area of hypertransmission of at least 250 microns with corresponding attenuation or loss of the RPE band, as well as some evidence of loss of the overlying photoreceptors. Now, the hypertransmission defect component of this definition, of course, is what we use, especially at en-face imaging, to measure the atrophy. So we measure the hypertransmission defect, and that can be useful to track the growth of atrophy over time. So with that as covering really a whirlwind through atrophy, I want to switch now to neovascular AMD. Historically, the gold standard for identifying macular neovascularization was dye-based angiography, fluorescein or indocyanine green. But this is sort of really the takeaway summary slide, that in 2025, fluorescein angiography is largely used for confirmation of diagnosis on certain cases and when treatment response is not as expected. ICG remains the gold standard for PCV diagnosis, but dye-based angiography overall is now largely a secondary tool in diagnosis and management, as I'll illustrate. So those of you who've been around at this for several years have seen this evolution from a shift from an FA to an OCT-based classification of lesion types. And I want to say that I think this classification is actually useful and important. When you have type 1 neovascularization below the RPE, there's evidence to suggest that it may protect against the development of atrophy if exudation could be controlled. And in particular, we have shown that those lesions can develop a neochoriocapillaris, which seems to be the substrate that is supporting the RPE and photoreceptors. On the other hand, if you have very large pigment epithelial attachments due to these type 1 lesions, that can be a negative prognostic sign, as it can increase the risk for development of an RPE tear, as we showed in this post-hoc analysis from the Hawk and Harrier trials. In addition, of course, if you have polypoidal lesions, patients may have, in some cases, a suboptimal response to anti-VEGF monotherapy, although the newer second-generation agents seem to be faring better. And I'm not going to, I suspect Dr. Vorporn is going to get into more detail on this, but of course we have some clues now of being able to recognize PCV on OCT that have been described by a few different groups now. Now, type 2 neovascularization is also important to recognize. It appears as subretinal hyperreflective material in OCT. Again, not a trivial feature to identify, as this kind of material can be associated, especially if it's thicker, with poor visual outcomes. And we showed this in the long term as well in an 8-year follow-up study. And so this is one of the reasons why we believe that aggressive treatment to eliminate SHREM as early as possible is important. This is a more recent post-hoc analysis from the Hawk and Harrier trials, where you can see that in the blue curve, patients who had SHREM on OCT, they still had a visual improvement, but you can see it's lower compared to patients who did not have SHREM. And in fact, that was the main variable. In just about every study, when you look at variables that predict treatment response, SHREM comes out. And it should surprise no one here, right? If you have material between your RP and photoreceptors, that's probably not a good thing. Finally, and I just want to say that it's also become an important biomarker as people have been developed, as many companies have now talked about targeting treatments to deal with fibrosis. And in this analysis, again, we showed a difference between brolucizumab and aflibercept, greater reduction in SHREM in this post-hoc analysis of Hawk and Harrier in brolucizumab-treated eyes compared to aflibercept. Now, finally, I'll just switch to type 3 neovascularization. Again, I think that's also quite important to recognize. This is an intraretinal origin from the deep capillary plexus. These patients typically respond very well to anti-VEGF monotherapy, but virtually all of them, this study, they said 86% in my clinical experience, 100% of patients with type 3 neovascularization will go on to develop atrophy. And some individuals, for that reason, have suggested a PRN treatment approach compared to treat and extend for this subgroup of patients, although I think that still needs to be evaluated in prospective trials. So far I haven't said anything about OCT angiography. So where does it fit into the diagnostic paradigm for neovascular AMD? We certainly know that OCTA can do a brilliant job of displaying the intrinsic vasculature of these, especially type 1 and type 2 lesions. There's no question it can be quite effective in that regard. And so, I talked about the importance of identifying SHREM. But SHREM can be from many sources. It doesn't always have to be neovascularization. It could be the exudation, the hemorrhage associated with the neovascularization. And this is where OCT angiography can improve the specificity of structural OCT by identifying the actual intrinsic vasculature. Type 3 neovascularization can sometimes be more tricky to identify. You have to scrutinize for it, but you can identify in this example here of an area of intraretinal neovascularization that's now extended inferiorly towards the sub-RP space. Polypoidal lesions are variably seen on OCTA. That's why I say that ICG remains the gold standard. You certainly can identify inklings of them, but sometimes it's very difficult to resolve them as specific polypoidal lesions using this approach. Cases where OCT angiography can be especially useful is where dye-based angiography is difficult to interpret, like patients with chronic central serous, where there can be staining of the RP alterations that's difficult to distinguish from leakage. This was a patient with CSR who was observed, had nice resolution, but presented 11 years later with recurrent subretinal fluid. But now we could see an interesting new finding with this double layer sign. In fact, OCTA confirmed the presence of neovascularization in this case. And of course, it's important to recognize patients with early neovascularization without fluid because these patients do have an increased risk for conversion and may need to be monitored more frequently. So to summarize, atrophy can be assessed with and measured with multimodal imaging. I think color photography or flash color is the past. The present has been blue fundus autofluorescence, but for my money, it's these newer technologies that we're going to be using going forward. Measurement and monitoring of GA has become important because we'll hear more about therapies for GA later on in this session. And dye-based angiography has largely been supplanted by OCT and OCTA, but ICG still remains the gold standard for PCV. Thanks very much.
Please.
Yeah, great talk. As usual, Vas, and welcome to the session. Something you've been working on is the choriocapillaris layer, and it's something I've also asked you earlier, is how far or how close are we to, quantifying choriocapillaris flow defects and, finding a value or a trigger towards, neovascularization onset?
Yeah, thanks for that question, Anand. I'm always afraid to answer quantitative questions with Joe Carroll in the audience, but because he's often reminded us that we really need to adjust for things like axial length to get reliable measurements. But having said that, I think our group, as well as several others, have spent a lot of time in trying to develop repeatable protocols. Maybe we're repeatedly measuring them wrong, but I can tell you that we can repeatedly measure them and then track them over time. So it can be done. You do have to have good quality imaging, and segmentation accuracy is quite important for being able to identify the choriocapillaris. But I think for my money, even though I think everyone in this audience, many people have experience with OCT angiography, use it for many reasons, for identifying non-perfusion retinal neovascularization. But for my money, the greatest contribution of OCT angiography is going to be our assessment of the choriocapillaris.
Great. Well, that's a nice summary, Wes.
Yeah,
I think we can move on to the next speaker.
You want to go? Yeah. Okay. So it's a pleasure to invite Dr. Jun Kong to speak to us on the benefits and limits of geographic atrophy treatments. Dr. Jun Kong.
And that's going to be a pre-recorded presentation.
It's a pre-recorded presentation. Can we have her presentation on, please?
I'm Neil Bressler, and I look forward to presenting the benefits.
That's not the correct one.
Geographic atrophy treatments in 2025.
Okay, I guess Neil's going to
I'm presenting this with my faculty colleague, Dr. Jun Kong. I'm happy to announce that Dr. Kong joined our full-time faculty on the tenure track at Johns Hopkins University School of Medicine just last week on April 1, 2025, and we look forward to our further collaborations with her both here and with her connections throughout Asia. These are my financial and other disclosures. Dr. Kong has no other financial disclosures. This is a typical example of a patient who develops geographic atrophy. Typically, they are in their 80s or 90s. They may have 20/20 vision, as this patient had in 2009. 4 years later, the central visual acuity on the eye chart still measures at 20/20, but the patient notices some pericentral scotomas that begin to interfere with reading very fine print. Another 3 years later, 7 years after the initial presentation, the patient remains 20/20, but more geographic atrophy can be seen when we obtain an OCT and we get this infrared imaging, which is a very good way of looking at least as good, if not better, than having the autofluorescence or other ways of analyzing geographic atrophy. 10 years after first presenting, now the patient notices some central visual acuity loss in addition, down to 20/40, a 3-line loss, and more geographic atrophy involving the central macula. The growth rate typically is about 2 millimeters squared per year, and that's what you're looking at here. So there was general excitement when the FDA approved pegcetacoplan in February of 2023 for the treatment of geographic atrophy based on several randomized clinical trials. And then in August of 2023, avacincaptad was approved by the US FDA as well based on the clinical trials of GATHER1 and GATHER2. And yet, just a few months later, the European Medicines Agency recommended refusing market authorization for pegcetacoplan for the treatment of geographic atrophy. This was reevaluated, and again in June of 2024, the AMA again refused marketing authorization based on all the available data that they had at that time. They noted that it slowed the growth of geographic atrophy lesions, but the amount of slowing of the growth was not associated with any clinically meaningful benefits for patients' everyday functioning. And there was a safety problem. There was a significant risk of adverse events in terms of developing choroidal neovascularization and rarely some eye inflammation. And so they concluded they could not establish a positive balance of benefits outweighing risks and therefore refused market authorization. Now, since then, it has been approved in a few other places in the world, including Australia, but not everywhere. Limitation number 1, there was a lot of loss to follow-up. If we look at the patients that were assigned to pegcetacoplan monthly, more than 30% in one of the 2 trials and 29% in the other trial had loss to follow-up at the 24-month visit. We don't know what happened to those patients, and we can do all sorts of statistical analyses to try to impute for their missing visits, but nevertheless, our confidence is diminished the more and more people don't return for follow-up. Limitation number 2, the difference in the growth is actually minimal. Yes, you may hear that there was a 20% reduction with every other month therapy and maybe slightly greater with monthly therapy of pegcetacoplan. Yes, that's a relative growth that was reduced by 20%. But what's the absolute reduction? It's very small here. If you look across to the y-axis, at 1 year, it's the difference between 1.5 and 1.75 of growth of millimeters squared of geographic atrophy. If we look at 2 years, the control group's about 4 millimeters and the treatment group is about 3.25 millimeters squared. What does that mean? Does that make a difference at 1 or 2 years? If these patients are in their 60s, 70s, 80s, or 90s, will that make a difference over 10 years? We don't know if the therapy will continue to have this difference, but the magnitude I want to emphasize to you is very small. What's 3/4 of a millimeter squared? If we look in detail at 1 year, the absolute difference from this relative decrease of 21% was 0.4 millimeters squared between the control group, the sham group, and the pegcetacoplan group. And there's a confidence interval around that. That's just the point estimate. The real answer is somewhere between 0.64 and 0.18. If we look every other month, it's even less. It's 0.32. And the confidence interval is somewhere between 0.54 and actually plus 0.9. It shouldn't be minus, it should be plus 0.9. The 2-year outcome, the absolute difference is 0.63 to 0.9 squared, depending on the trial. What does this translate to? What's 1 millimeter square of growth? This slide shows you 1 millimeter square of growth. On the left, 4.58 millimeters squared of geographic atrophy. On the right, there's 1.15 millimeters squared more growth. You can barely see it, and that's probably why it did not translate into any visual function benefit. It can be measured, but it may not be large enough magnitude to have any clinical relevance. Limitation number 3, the anatomic benefit was not associated with any pre-specified secondary outcomes that were for visual benefits. These vision benefits were presumed to develop with time, but there's no evidence that there's any vision benefit over time. For visual acuity, there's a substantial loss in visual acuity. On average, all groups lost 7.5 letters by 2 years. That's about the difference between using laser to treat DME and using anti-VEGF to treat DME. On average, the groups differ by 7.5 letters. The same thing here, there's substantial loss. It's not that you can't measure loss, you can. It's just that that amount of vision loss was the same, regardless of whether the participant was assigned to pegcetacoplan or assigned to sham. This was true not only for best corrected visual acuity, but for other pre-specified vision outcomes: maximum reading speed, functional reading independence index, a well-characterized approved survey to measure how someone might read, or the mean macular sensitivity within specified areas in those participants that had micro. Yes, there are post hoc analyses that in certain groups show that there might be other benefits, but those are generating hypotheses. They weren't the primary or pre-specified secondary outcomes. Finally, the fourth limitation is a safety limitation. There was a much higher rate of developing choroidal neovascularization within 2 years in the groups given pegcetacoplan either monthly or every other month, compared to the 4% event rate of developing choroidal neovascularization in the sham group. And rarely, this is less than 1 in 1,000, but still, it exists, it's not zero. Participants or patients may develop retinal vasculitis in association with these injections. In fact, 14 of these eyes that were looked at in detail among 13 patients developed substantial occlusive retinal vasculitis with anterior chamber inflammation, with permanent visual acuity loss, and some of them even anterior segment neovascularization. So we might ask ourselves, why might a regulatory agency come to 2 opposing conclusions in 2 different continents, despite the public health impact of geographic atrophy from macular degeneration? And this brings us to discussing the benefits and 4 limitations of evidence that we should consider in the management of geographic atrophy, which may start on this fundus photograph with lots of drusen and just a small area of atrophy, which inevitably over the next 10 years will continue to grow and then be associated with some central visual acuity loss. The good news, we have 2 FDA-approved treatments for geographic atrophy in the United States and in some other locales in the world. Primary outcome showed less geographic atrophy growth. That led to approval of the first treatment for this public health problem. However, the maybe not so good news is the magnitude of the anatomic difference is very small. Follow-up was less than 80% at 2 years, which diminishes our confidence even in this anatomic benefit. But most importantly, the anatomic benefits were not associated with any clinically meaningful benefit across visual acuity, low luminance, reading speed. Vision outcomes, again, should not trump. Vision outcomes, again, should trump anatomic outcomes. There were common safety concerns. of an increased risk of developing neovascular AMD and rare safety concerns of occlusive vasculitis. Thank you for letting me share that.
So Neil isn't on the Zoom, but we can certainly still, we're happy to have questions and discussion if there are any questions or comments from the audience.
Could you come to the mic,
I think
please?
the question, was the question you want us to summarize the, well, I think Neil's summary, to summarize his presentation, was that he talked about the data that exists for the complement inhibitors, showed that there was evidence of an anatomic benefit that met the primary endpoint, but then highlighted that there were some loss to follow-up that he thought affected some of his interpretation of the confidence of those results, and highlighted that the functional benefits are somewhat more difficult to ascertain for those patients, and hence might be why two different regulatory agencies came to a differing conclusion. I'll say it for myself in my own practice. You didn't ask the question, but I will say that we do treat some patients. We discuss with them the details of the results. And because some people have questioned whether the residual photoreceptors that are being saved, that some have shown are saved, or whether they're functional. And so I can't answer that question for sure. But for some patients, they would rather save those photoreceptors in the hopes that there may be other treatments in the future. Once they're gone, they're gone. And so we always respect the patient's values. But I do think that Neil did a very detailed dissection of the data. It's important for us to present them to patients. And ultimately, we do what they want us to do, as long as they understand things clearly.
Yeah. So I had two questions for you, Dr. Sada. First is, how has been the adoption of these agents in your practice? And second thing is, like when we are treating wet AMD patients, we look at OCT biomarkers of fluid to decide whether to treat or to extend or what. So what is the endpoint of treatment for these dry AMD patients?
Yeah, that's a great question. And so as I said, I treat a small number of patients who I've advised and discussed. I think I don't think these are necessarily trivial breakthroughs. I think it's important because we haven't seen anything to slow the anatomic decline. But I present very similar to Neil in terms of the limitations. And I said some patients want to pursue the treatment. In terms of which patients, there are some biomarkers that you alluded to that correlate with people who may progress more rapidly, whether they're fundus autofluorescence patterns, or now on OCT we can measure the photoreceptors surrounding the GA lesion, and people have shown that photoreceptor loss surrounding the GA lesion may be a risk factor for faster progression. But I don't use any of those. What I do in my own practice is I won't consider treating a patient unless I have 6 months of prior data to know what their trajectory of progression is. And so then what you're effectively looking for is some deflection of that slope of progression. And so that's how I even consider whether there's a patient I would treat in the first place, because some patients don't grow very rapidly. And I think that if you're going to start treating them, you want them to stay on therapy, and that kind of information can be helpful in that regard.
And what is the endpoint? When do you stop?
There is no endpoint. The endpoint is death in this case, or a better therapy. I hate to say it, but that's the fact. Or when the patient just gets exhausted, they don't want to do that, right? So some patients, again, you emphasize to them they're not going to see a vision benefit, that they're going to see their vision's going to decline. And yet some patients, if you start treating, they'll say, Dr. Sada, my vision's still getting worse. I don't want to continue. And then I say, well, I told you that it was going to continue to decline. And so some patients don't continue. It's a challenge.
Thank you.
Just two questions. One is, do you differentiate between an active GA lesion and an inactive GA lesion?
And well, that's what I was just describing. I said I look at the 6-month previous trajectory to know the growth rate.
If it is inactive, then you don't treat.
Correct.
And what is the benefit ratio for these patients?
As I said, it's a patient judgment, right? So it's, I present the results to the patient.
No, because the number of inflammations which you're seeing is quite a large number of patients.
No, the inflammation is relatively low, and it seems to be primarily a first injection event. So what many physicians who treat, there are many physicians who treat many more patients than I do, because as I said, I treat a relatively small number of patients who are properly informed and they want to continue treatment. I think it's very valuable. But there are others who are treating many more patients, so they'll see these events. I haven't seen one of these events because they're relatively uncommon. But generally, people will treat the worst eye first. And once they've confirmed that the patient doesn't have a reaction, they'll move on to treating the other.
So do we have a data of registry to evaluate all these patients together?
No.
Like, no, you don't.
How do we
Great.
explain this?
We need to move on.
Yeah, we need to move on. I think we have another presenter in the Zoom already. Dr. Sinyon Sang, she's going to present what is pachychoroid. Please, Sinyon.
Morning, chairs and everyone. It's my great honor and pleasure to have this opportunity to deliver the invited topic, what is pachychoroid? This is my financial disclosure. My talk today will focus on the discovery of pachychoroid, the diagnostic criteria of pachychoroid and the underlying mechanisms, the research progress and unsolved problems about pachychoroid and pachychoroid spectrum disorders. As a retina specialist, we all be aware of the clinical understanding of fundus diseases is accompanied by the development of ophthalmic imaging. Among all the non-invasive fundus examination tools, OCT has been the fastest advancement in recent years, significantly impacting clinical practice. The innovation and the progression of OCT are the foundation of the discovery and establishment of the concept of pachychoroid. The boundary between the choroid and the sclera has evolved from being invisible by TD and SD OCT to can be shown by EDI OCT, and finally to completely clear due to the upgrade ISS OCT, which has made a significant advancement in depth and detailed visualization of the choroid. First, let's review the anatomy and function of the choroid. The choroidal capillaries, subtle and hallux layers, which among the 5 choroidal layers are indeed rich in blood vessels and play critical roles in supplying nutrients and oxygen to the retina and surrounding tissues. The prefix pachy is derived from the Greek word, which means thickening or hypertrophy. In 2013, Dr. Warrow and Professor Belifrand were the first to report and describe pachychoroid spectrum disease, thereby confirming the concept of pachychoroid in choroid. In 2017, my team and Dr. Timo Salai introduced the concept in China. Over the 10 years since 2013, although we have a deeper understanding of pachychoroid and pachychoroid spectrum disorders, there are still a lot of unknowns, including the quantitative diagnostic criteria for thickening choroid and underlying mechanisms of pachychoroid and pachychoroid spectrum disorders. First, I would like to discuss the issue of the diagnostic criteria for pachychoroid. Currently, there's no unified international standard for measuring the thickness of the choroid or define the cutoff value of the pachychoroid. For example, for measuring the thickness of the choroid, some studies use a manual management, which can induce management and methodology errors. The OCT machine equipped with the EDTRS-based automated measurement method is currently the most objective measurement technique. By performing 360-degree repeatable subfoveal choroidal thickness measurements, overlaying the data, it provides more accurate results and reduces human error. Secondly, current diagnostic criteria cutoff values for pachychoroid is not objective. Most studies use the average choroidal thickness of the study population, with the standard deviation added or subtracted to determine the value. Some studies directly use the threshold of greater than 228 micrometer as a diagnostic criterion. However, choroidal thickness in healthy individuals varies physiology factors such as time of day, age, and other conditions. Therefore, the cutoff value based on physiological indicators such as age, sex, refractive error, and anterior chamber dips are more reasonable. To answer the clinical questions and establish an objective criterion for pachychoroid, we established a pachychoroid large sample size cohort using a likelihood statistical analysis for the diagnostic cutoff value of pachychoroid. And in this study, we controlled age, gender, diopter, refractive error, and anterior chamber dips as the physiological parameters. An objective diagnostic criterion has been proposed, and its performance was compared with the traditional average value-based standard using ROC curve analysis. The results confirmed that it's more accurate and reliable than the conventional metrics. As you can see, the diagnostic values are determined based on different age groups. Based on this large cohort, we further confirmed that the subfoveal choroid thickness was negatively correlated with age in healthy males and females and has a weak positive correlation with the increase of diopter. We also found that about 20% of eyes with neovascular AMD and 40% of eyes with PCV with non-pachychoroid. FFCT in the CSC group is higher than that in the neovascular AMD, PCV, and normal control. FFCT in the Pachy PCV groups is higher than that in the non-Pachy PCV and the normal control group. Similarity in the Pachy and non-Pachy neovascular AMD group. To further answer the clinical questions, is PCV is a subtype of neovascular AMD, and what the underlying mechanism of PCV and neovascular AMD? We further investigate the blood flow in the CC hallux and Satus layers. The multivariable logistic models found that after controlling for age, sex, and diopter, the blood flow in the CC and hallux layer in the Pachy and non-Pachy AMD, PCV, and CSC group is significantly higher than that in the normal group. But for the Satus layer, the blood flow in the Satus layer has no difference in the CSC and the normal groups. But the PCV and the neovascular AMD groups is significantly lower than that in the normal group. Why only Satus layer in CSC does not decrease is age-related to blood flow in different pachychoroidal diseases phenotypes. To answer these questions, we looked back for the baseline characters. We found that the gender and refractive error or other parameters can be matched. Only age cannot be matched between the CSC and the PCV and the neovascular AMD group. Patient in the CSC group is much younger than that two groups. We further found that among all the age-related microvascular dysfunction factors, collateral circulation is the primary risk factor as agent leads to a decrease in the number, diameter, and the tortuosity of collateral vessels. From our next study, we found that CSC poses the majority of diffuse choroidal capillary circulation. PCV poses the majority of local CC type, and no CC was found mostly in normal subjects, indicating that the decreased compensatory ability of collateral circulation and choroidal blood vessel remodeling contribute to the phenotype of the different in the pachychoroidal patients. Furthermore, we identified the role of dyslipidemia in the pathogenesis of pachychoroidal diseases, identifying some new biomarkers, including the ratio of LDL-C to HDL-C, as well as HCY, are differentially regulated in PCV and neovascular AMD. We also identified the RCT pathway and the LXR agonists that contribute to the pathogenesis of pachychoroidal diseases. Furthermore, we also found that genetic polymorphisms, lipid metabolism pathway also differentially regulated in the pathogenesis of PCV and neovascular AMD. Our team is also using AI to further investigate the clinical phenotype difference between different phenotypes of pachychoroidal diseases. Till now, we have published several manuscripts and research is still going on. Okay, so take-home messages. The diagnostic criteria for pachychoroid remain poorly defined. Our team developed objective criteria integrating demographic and clinical factors, including age, sex, refractory error, anterior chamber depth. So thick choroidal can also exist in healthy individuals, requiring comprehensive imaging evidence for PCD diagnosis. PCD has diverse causes. Our work focuses on the role of the lipid metabolism pathway in the pathogenesis of PCD. Also, AI-based tools show potential for improving PCD diagnosis and prognosis. Finally, I just wanted to emphasize that we have entered the era of molecular imaging. We are looking forward to more groundbreaking advancement for deeper understanding the underlying mechanisms of pachychoroid and pachychoroid spectrum disorders. Thanks to our collaborators and our team collaborators. Thank you for your listening.
Thank you. Well, Sinyon, are you there? Are you there at the Zoom?
Yes, hi, Person.
Oh, hi.
Yes.
Hi, nice
Hi,
meeting you.
Person.
Hi,
Nice to meet you.
Yeah,
Person,
great
I
talk.
met.
Great
Thank you.
talk. Well, may I ask the audience first, do you have any question for Sinyon? She's in the Zoom, so we can talk with her. Well, may I ask you a question, Sinyon?
Yes.
Well,
yes.
how you diagnose pachychoroid in myopic eyes? For those with...
Good question.
Yeah.
Yeah, you're right. Because I think that the thickness of the choroid decreased with the diopter, and for the high myopia patient, seems to have a thick, much thinner choroidal thickness than the normal person. So after we adjust with the diopter, the cutoff value of different age for the pachychoroid is quite different from the healthy eyes. So we have diagnostic criteria and use the multivariable method, logistic method to determine the cutoff value for the high myopia patients.
I see.
So the diagnosis cutoff value is quite different from the healthy person or the other, or without the high myopia patients.
Okay, great.
Quick question, Jin Yang. Great talk.
Thank you.
I just want to know if you have any markers or triggers. We often seen that there's a lot of choroidal remodeling happening. So,
Yeah.
and we also see that in some patients, in the same patient, you have PCV and sometimes CSCR in the other eye, or over time develop PCV morphing into a CSCR-like picture, or vice versa. From your large and impressive, data set with pachychoroid, have you at all identified any markers which suggest that there might be a, movement from one pathology to the other?
Great question. Yeah, we in our large cohort, we made some patients, for example, some chronic CSC patients developed to PCV. We pick up some imaging biomarkers. For example, the double layer sun for the highest of the double layer sun, or the timing for the resolve of the subretinal fluid may be useful marker for the progression to PCV for the CSC patient. Some markers we are still studying. Very good question.
You have a question? Yeah, please.
Yeah, one more.
Yeah, I have a question related to myopia. In continuation to the question first asked, there is a choroidal thinning in myopia, if I'm correct. And the therapies that are given for myopia correction, for axial length correction, like atropine, cause choroidal thickening. So how do you differentiate between pachychoroid and the treatment-related thickness of the choroid?
I'm sorry, how can I differentiate
between pachychoroid and the treatment-related thickening of the choroid?
The thickening of the choroidal thickness, you mean? I can't hear clearly.
During atropine treatment leads to
During
choroidal thickening.
So,
Oh,
so
that's a very
John,
good
he's
question.
asking that when
Yeah.
you treat a myope with atropine, the choroid can thicken. So he's asking how that interferes with your assessment of the presence of pachychoroid in that setting.
Yeah, this question actually related to the criterion for pachychoroidal diseases. Actually, for pachychoroidal diseases, we should identify that the pachychoroid is a chronic thickening of the choroid, and you should identify the diffuse choroidal leaking, so we can diagnose the pachychoroidal disorders. So I think that question related to the criterion about the pachychoroidal diseases.
Okay, great. Okay, it's a pleasure to invite Dr. Gavin Tan next to talk on something very interesting and something futuristic, home monitoring to manage AMD, something that's going to be very relevant in times to come. Dr. Gavin.
On this topic. So these are my financial disclosures. So we know in age-related macular degeneration, we have a very successful treatment, and that has really revolutionized the way or the outcomes we get with exudative age-related macular degeneration. We know there are various treatment strategies where we keep trying to push the limit of how long we can extend treatment because patients do not want to come back for monthly injections. And we know there's now an increasing number of pharmacotherapeutic and device-related options, and in future gene therapy, that's really going to move the needle how long we can extend these patients. So is extension all great? Well, yes, but also no. So we do create a problem where we are seeing, we are imaging, and we are evaluating our patients less and less. And there is then a significant risk that there may be events that happen in between our monitoring intervals. There may be development of new disease in the fellow eye, which can be a significant problem. They're picked up late, since they usually will end up with poorer vision. And of course, we really want to figure out if is there a better way to reduce our treatment burden with truly individualized treatment. And home monitoring may be a means to address these issues and provide solutions. If we look traditionally, what did we used to, or maybe most of us still currently do for home monitoring of visual function? It is an Macular chart. That is a patient self-actuated test where you're looking for symptomatic change in the patient's central visual function. There are a lot more devices that rely on maybe the same principle, patients doing self-doing a functional test, and of course, because these devices can then objectively try and measure the patient's performance, they can look out for changes in visual function at an earlier stage and in a more reliable basis. I think the device that has been the most successful or reliable with this is the 4C home monitoring device that has been around for perhaps almost a decade. And this device relies on preferential hyperacuity, perimetry testing to identify metamorphopsia. And this is an example of what it measures. It measures performance, and it needs to look at performance over time and against a baseline to detect a change in function. In their randomized clinical trial, which had almost 1,000 or more than 1,500 patients, it was actually abandoned early because at a pre-specified interim analysis, they found 82 patients had progressed to CNV, and there was a significantly smaller decline in visual acuity from baseline to CNV detection in the intervention arm compared to the standard of care arm, and that's why they felt it was no longer ethical to continue. A larger real-world data analysis showed that the home monitoring system helped to detect wet AMD conversions at better than 20/40 or better in 81% of patients compared with 30+% in standard of care alone. So this is effective at detecting disease earlier and preventing visual loss. So the question is, do I need a special device to do it? Many other companies have tried to do this on your mobile phone. In theory, a nice concept. In execution, maybe not always that effective. All Eye is one of the apps that have tried to do this. This relies on vernier hyperacuity. We did a pilot program during COVID where we got 2,000 patients to offer this app to use with a 32% sign-up rate with various diagnoses. And again, it would trigger an abnormal, consistent abnormal results, would trigger a notification to the clinic, and the clinic can call the patients back. When we looked at the triggers that occurred, there were significant positive triggers that allowed us to pick up 7 patients with events before they were inclined to come back to the clinic. But if you notice, the positive predictive value was actually not great. It was pretty poor, less than 25%. And because of the design of the study, we couldn't assess accurately the sensitivity. There are other options. There is the My Vision Track app, which showed, again, very encouraging data in the feasibility study. Again, the major problem here is the specificity and sensitivity is a little bit less than ideal. There was a larger randomized control trial that tried to evaluate how these apps actually perform, and that was done in the UK, the Monarch study. They looked at 2 apps and a non-app-based kind of self-monitoring program. And what they did find was that the AUCs were in general very, very poor for detection of disease, were all less than 0.6. Only one test had a score that was associated with lesion activity, and their conclusion was poor diagnostic accuracy. And you can look at these AUC curves, they're more or less running down the middle. So these tests have limitations when you try to apply them in a real-world fashion. And beyond being an accuracy, there are issues with compliance in the real world. This data was from a group of clinics in the US, which tried to evaluate how effective the 4C system was in their program, and they found that a meaningful proportion of eyes never used the device at all, and all could not establish a baseline. And overall, the frequency of use was low, and continuous use of the device decreased over time. And that again is seen in the long-term results from the ALOF group, which found that over time, the frequency of use, as you can see up here on the right, decreased with time. But their data was encouraging in that they still found that 52% of the conversions could be detected with the system alert before the patients were symptomatic, and that's an advantage for them. And they did find that when they looked at the long-term visual acuity of the patients in this program, they maintained an excellent VA in spite of conversion. But again, these patients would be a self-selected group that are more likely to come back for early treatment and intervention if they had symptoms. The next area that's really potentially may change the way we manage our patients is home OCT. It really does have the potential to give you a truly personalized treatment interval. You're not waiting for your monthly, 6-weekly, 8-weekly, 12-weekly visit. You're actually getting them to do it at home all the time. And has been shown that patients can do this reliably, 80 to 90% successfully at home. So could it really change the way we individualize care and detect disease? But there are challenges. Firstly, you need to have image quality that's sufficient in a low-cost device. You need to have an analysis infrastructure. Imagine if your patient takes 2 OCTs a day, 365 days a year. That's for you 700 over OCTs to review, and that's for one patient. Imagine if you took care of a pool of 10,000 patients, you would not be able to cope. So manual interpretation is very laborious and must be addressed with artificial intelligence. And you have the usual things, coverage, reimbursement issues, and usability issues. The most mature device is the Notel device. In their pivotal trial, they looked at patients with a mean age of 77 years, and they found that 97%, again, clinical trial cohorts are very selective for the smartest, most compliant patients, but 97% could obtain successful scans. And in this study, they did the 5,400 scans altogether, and they found that in terms of looking at the endpoints, there was a good agreement in terms of detecting disease with a positive and negative predictive agreement of more than 0.8. And the visualization component also showed that the most patients were able to set it up at home. They performed an average of almost 6 scans per week, and the scan time averaged about 48 seconds. So 6 minutes of their lives, a very small proportion. They also evaluated their AI system for interpreting these OCTs because you can't do this manually. And they did find that, surprisingly, the home OCT had less variation because they're probably being done at a more frequent interval. And comparison of the 2 images and the grading processes showed a very high level of agreement. And they are not the only company on the market. This is data from a company that has been acquired by Heidelberg that looked at another home-based OCT, and they showed a good level of sensitivity and specificity for various clinical features and disease activation features. And we know other companies such as Zeiss have them in development as well. I think the biggest potential is really if you have a large amount of data, you may have the potential to improve the personalization of AMD management. And we always base our prediction algorithms based on 1 or 2 OCT scans. If you had serial OCT scans on a daily basis over time, it would really exponentially improve the amount of data you have, and that might enable us to pick up better markers for predicting all of the above: response, treatment interval, and so on and so forth. But there are still many barriers. Again, you need patient selection. Compliance is a problem. AMD patients are not spring chickens, unfortunately. They tend to be elderly, have multiple morbidities, poor performance status, and often may have limited technological expertise and experience. In a lot of real-world studies, as I mentioned, compliance is still poor. It can range from 25% and above, and we still haven't addressed the cost and logistics and issues with patient safety if you end up with a very high false negative rate, which is almost 50% for neovascularization with some of these app-based hyperacuity tests. So in conclusion, I think home monitoring holds a lot of potential. These hyperacuity-based tests have limitations because they're dependent on patient performance and may perform worse in real-world studies. Home OCT looks really promising because it's been effective in clinical trials, but the logistics, cost, and compliance issues will still need to be addressed. And I think we look forward for further development in this field. Thank you.
Thank you, Kevin. Thank you. Well, is there any question? If no, I have a question for you, Kevin. Well, a quick question. I think the images from home OCT device, they're kind of different from the conventional OCT images. So if you want to do AI for that, you need a kind of data set for the home OCT only. So it's going to be quite difficult. What do you think?
I completely agree. I have seen the quality of the Notal scans. Again, they're much poorer than a Heidelberg scan. Same with the potential Zeiss device. I think this company that Heidelberg acquired, the scans are a bit more similar to what we normally experience. But again, I think whoever is going to set this up is going to need to do big clinical trials to get enough data for it to be effective. So that's going to be the limitation.
Thanks very much, Gavin. Because of time, we're going to move on. Thank you. It was excellent. So I'm very pleased to introduce our next speaker, Dr. Voraporn Chekit-Mongol. And her talk is entitled Challenges of Polypoidal Choroidal Vasculopathy. Please, Dr. Voraporn.
Thank you. PCV is currently considered as a variant of type 1 macular neovascularization, and it is introduced by Professor Janussi since 1982. And now it has been almost 40 years that we know much better about PCV through the increasing number of research. To diagnose PCV, as Professor Sadda mentioned earlier, ICGA remains the gold standard to diagnose PCV. And we have the standardized criteria, the Everest criteria, to guide us how to do the diagnosis. But if ICGA is not available in your clinic, now we have several non-ICGA diagnostic criteria to identify PCV with relatively high accuracy. So I think challenges in managing PCV right now is not about diagnosis, because we can diagnose even without ICGA. But we still found some challenges to select the best first-line treatment for some individual patients, and also what should be the best long-term management for PCV, which we know that have high recurrences. For treatments of symptomatic macular PCV, I think it depends on the patient's clinical presentation. If the patient presents with breakthrough vitreous hemorrhage, you can give anti-VEGF injections and may end up with vitrectomy. If your patient presents with massive subretinal hemorrhage, you can give anti-VEGF injection, perhaps perform pneumatic displacement. Some surgeons might consider vitrectomy with subretinal TPA injection, but this option is still controversial. If your patient presents with leakage with minimal hemorrhage, we have several options proven in large RCT, including combination treatment between anti-VEGF and PDT, and several options of anti-VEGF monotherapy. According to the recent global shortage of PDT, I think the trend right now moves towards anti-VEGF monotherapy. And especially after COVID-19 pandemic, I think we would like to decrease the burden in clinic. So now most of us apply treat and extend for PCV. And currently, we have the recent APURS consensus and guideline, first authored by Professor Paisan, our chair today. And this guideline suggests that we can consider anti-VEGF monotherapy in PCV, especially for those who present with small lesion, less than 1 disc diameter with good vision. And we can reserve a combination therapy for those patients who are not able to have regular long-term follow-up. Now let's take a look at some case example that we use anti-VEGF monotherapy in PCV. This patient present with massive subretinal hemorrhage and confirmed on OCT and ICGA to have PCV. In this case, we are fortunate to be able to start with a aflibercept injection. Following 3 doses of monthly loading doses, you can see the complete disappearance of PED, likely reach complete polypoidal regression. We follow this patient every month for 1 year and no recurrences. So she got only 3 injections and it remains inactive. This patient is an example of a very good response to anti-VEGF monotherapy. But unfortunately, not every patient in your clinic will have good response like this. Let's move to the next one. This patient presented with giant hemorrhagic PED in the left eye. OCT across the lesion, you can see subretinal fluid and huge sharply peaked PED. In this patient, you can see the thin choroid, and I think everyone agrees that for patients with thin choroid, we would not prefer combination treatment with PDT because they will have higher risk for RPE atrophy and later vision decline. In this patient, we start with bevacizumab injection, and by the end of year 1, she received monthly injections of bevacizumab for 12 doses with persistent subretinal fluid and persistent giant PED. What should be the next management for patients with poor response to anti-VEGF monotherapy? We can consider add rescue PDT or switch to another anti-VEGF agent. And in this case, we switched to brolucizumab, and she had significant improvement after the first 3 loadings injections. So this is another example that if you found patients with poor response to one anti-VEGF molecule, you can switch to another molecule and the patient can show improvement of clinical outcomes. Now move to case number 3. This patient had PCV, and on ICGA you can see cluster polypoidal lesion. So we know that this case is one of the most difficult features to treat. This patient start with aflibercept every month for 1 year, but you still see persistent subretinal fluid and the growth of hemorrhagic PED. But we have no other options, so we continue monthly aflibercept for another year. But you can see the enlargement of hemorrhagic PED. By the end of year 2, we have new anti-VEGF agent at that time, faricimab. So we give faricimab monthly for 7 doses, but still enlargement of hemorrhagic PED and the disease still active. You can see subretinal fluid. What should we do now? Very lucky that PDT has become available again in Thailand end of last year. So we apply PDT in this case and the patient showed significant improvement. We can control the disease. The vision improved to 20/40 and we can extend the follow-up period to 16 weeks. So this case showed that in the very difficult case, even after extensive injections with expensive anti-VEGF like aflibercept and faricimab, sometimes rescue PDT still play a role in this difficult patient. Talking about treatment goals for PCV, in addition to visual acuity outcome and fluid resolution, the very important parameter is complete polypoidal regression. Why? Because several studies have shown that it correlates to the risk of recurrences. Here's the study from Korea and follow up PCV patients for 11 years. They found that after treatment, those eyes who have persistent polypoidal regression or incomplete regression will have higher long-term risk of massive subretinal hemorrhage. And also our study from Thailand, we found a risk for recurrences in PCV eyes receiving aflibercept, including the findings on post-treatment ICGA, incomplete polypoidal regression, and also the findings on post-treatment OCT, persistent PED with internal heterogeneous reflectivity. And these features on OCT, we have previously published that actually it is the features of incomplete polypoidal regression correlate to the findings on ICGA. So if you found these high-risk features for recurrence, keep in mind that don't stop injection right after it achieve like your treatment goal, but you better closely monitor these eyes because of higher risk for recurrences. Talking about the rate of complete polypoidal regression, because now we know that we want to achieve complete regression to achieve lesser risk for recurrences. This meta-analysis showing that for eyes that receive PDT, either monotherapy or combination, will reach around 80% of complete regression. What about anti-VEGF monotherapy? You reach only 42%. What about the new anti-VEGF agents that we have? It increased a little bit, but the maximum is just 51%. So what should we do? We cannot achieve highest complete polypoidal regression with monotherapy. So the new treatment goal for anti-VEGF monotherapy in PCV is to achieve inactive polypoidal lesion. What is inactive polypoidal lesion? So on OCT, you can see incomplete polypoidal regression without fluid. That is inactive polypoidal lesion that you would like to achieve after treatment. But remember that inactive polypoidal lesion still have risk for recurrences. So you should not stop treatment right away. You better give injections and extend the injection interval slowly to decrease the risk of recurrences. So in conclusion, challenges to manage PCV in 2025 is to select the best first-line treatment in some patients, and also how to manage difficult cases after anti-VEGF monotherapy. And PCV have higher risk for recurrences, so we should monitor them in the long run. Patient education is really crucial for PCV to help them better understand the chronicity of the disease and the importance of long-term follow-up. Thank you very much.
This is really a fantastic presentation. I have one quick question for you. You highlighted the importance of achieving total polyp closure for the best outcomes for patients. And so what have you found at baseline to predict who is going to be able to get total polyp closure? You talked about, obviously, after you start with, whether it's anti-VEGF monotherapy or a bispecific, to look for regression. But at baseline, can you tell who is going to have regression or not?
Yeah, that's a very important question. So actually, we have done another study to explore the risk factor, like which one can achieve complete regression. And very straightforward. Those who have higher number of polypoidal lesions, like more than 5 polypoidal lesions at baseline, will have lesser opportunity to achieve complete regression. And also the diameter of biggest polyp at baseline also contribute to who can achieve complete regression. Thank you.
Thanks very much.
Great. Thank you, Varapon. May I ask another speaker, Professor Neil Bressler? I think he's in the Zoom. He's going to talk about vitamin supplements for geographic atrophy or RP. Please, Neil.
I think we have a recorded talk.
Yeah, it's.
Yeah, can you
play it?
Get Dr.
Yeah, maybe
Bressler's
just play
talk on?
video first, and he may answer the question himself later on.
Hello, everyone. I'm Neil Bressler, and I look forward to presenting to you our thoughts on vitamin supplements for 2 major causes of vision loss for which we have little, if any, treatments at this time: geographic atrophy and retinitis pigmentosa. These are my financial and other disclosures. We first considered dietary supplements, such as those used in the age-related eye disease study, or AREDS, based on the original AREDS randomized clinical trial, where participants either received placebo, antioxidants, zinc, or a combination of antioxidants and zinc. These dietary supplements were shown to reduce the risk of eyes that had large drusen from progressing to choroidal neovascularization. But most importantly, there's no evidence that these dietary supplements reduce the risk of developing geographic atrophy, or in those eyes that had geographic atrophy, there's no evidence that they reduce the risk of further growth of that GA. This shows you the major outcome from the age-related eye disease study, where 28% of the eyes at 5 years assigned to placebo compared with 20% of the eyes assigned to a combination of antioxidants and zinc progressed to advanced AMD. Advanced AMD was either choroidal neovascularization or geographic atrophy, and this was shown in a subgroup of those participating in AREDS, those that had AMD categories 3 and 4. Category 3 was large drusen, and category 4 was having the advanced stage, either geographic atrophy or the neovascular form of macular degeneration in one eye, so that the other eye was at risk. But if we break down this information to see if these dietary supplements were protective on the left side or harmful on the right side, the odds ratios show that if you had geographic atrophy developing in the center over time, there was no difference whether you were assigned to antioxidants, zinc, antioxidants plus zinc in comparison with a placebo. And if you look at eyes that had developed any moderate GA, that is 360 microns or more in its greatest linear dimension, again, there's no evidence compared with placebo that any of these dietary supplements were protective. Regardless, people still lost a lot of vision, and it was worse if you had the advanced stage in one eye shown all the way to the right, or if you had numerous large drusen in both eyes or a large drusen in just one eye. Either way, you had an increased chance of getting central geographic atrophy, but it was no different whether you were assigned to placebo or the active treatment of antioxidants plus zinc, or zinc alone. So there's no signal that these supplements have any effect on developing geographic atrophy or having that geographic atrophy progress. What about AREDS2? Well, again, no evidence that when you look at lutein zeaxanthine, which was a new supplement tried in AREDS2, that it had any protective effect for central geographic atrophy, even when you adjust for multiple comparisons. And there were exploratory analyses looking at what happens if you use lutein zeaxanthine in place of beta-carotene. Again, there's benefit of taking these dietary supplements to reduce the risk of getting the advanced stage of macular degeneration when defined as either the neovascular form or central geographic atrophy. But if you break out those two components of that combination endpoint, the dietary supplements only were shown to reduce the risk of developing the neovascular form of macular degeneration and not the development of geographic atrophy in the center of the macula. Again, even when adjusting for multiple comparisons. But what about this publication that just came out at the beginning of 2025? Where some of the investigators at the National Eye Institute reported that the oral antioxidants and lutein zeaxanthine supplements might slow geographic atrophy progression. I emphasize the word might, into the fovea in participants that had AMD. This was a post hoc analysis, which means there were numerous analyses done over a decade. And this is the first time any of those analyses showed the potential that these dietary supplements might slow geographic atrophy progression to the fovea. When this is inconsistent with all other analyses that showed no benefit, we don't throw away the results, but we look at them as hypothesis generating rather than guiding clinical practice. They looked at just 208 eyes among the several thousand that were in AREDS2. And they showed only one outcome, what they called proximity-based progression towards the center of the macula. That means there was no GA in the center, and only looking at that progression towards the center was there a reduction of 50 microns per year, giving these dietary supplements. But there were only about 50 people in each group of the thousands that were analyzed. So whenever you start breaking down thousands of participants into small groups of 50 or 60, you might find a group that just by chance alone has a benefit. There was no benefit shown for the zinc groups, and it was only for what was called this proximity-based progression towards central macula. In AREDS and AREDS2, with many more eyes that had any geographic atrophy, this area-based progression was not different from randomization to antioxidants versus none alone. In other words, only this very specific group of 50 in each group. And so the conclusion is dietary supplements may reduce the risk of progression to choroidal neovascularization, but only choroidal neovascularization. There's no evidence that they reduce the risk of development or growth of geographic atrophy. So we give them to participants and patients that have geographic atrophy to try to reduce their risk of getting the neovascular or wet form. But the patient and the physician should not believe this is having any effect on the geographic atrophy. Now, what about using vitamin A or this supplement for retinitis pigmentosa? This got a lot of publicity in June of 1993 when Elliot Burson at the Massachusetts Eye and Ear Infirmary reported the results of a trial of vitamin A and vitamin E supplementation for retinitis pigmentosa. The results showed only vitamin A might have an effect on the cone electroretinogram, but no other outcome. And you don't want this to happen, but in this case, the Data Safety Monitoring Committee wrote a letter saying they totally disagree with the conclusions that there's any benefit to vitamin A. They point out that there were a lot of analyses that they saw that weren't shared in the publication that they believe weaken the argument that there's any benefit to vitamin A, and I strongly recommend you read all these letters to the editor that went back and forth because it so rarely happens. This vitamin A supplement, again, might have retarded the loss of some ERG amplitude, but Bob Massoff and Dan Finkelstein pointed out it really is inconsistent with what was seen. There was no vision function benefit. It had no effect on visual acuity or visual fields. And as I said, it's rare that a Data Safety Monitoring Committee actually writes letters to go at odds with the study chair of a randomized trial. This was again seen when lutein was looked at for RP. And again, no vision benefit. And it wasn't the primary outcome, it was a secondary outcome. And when the primary outcome doesn't work, looking at secondary outcomes should be hypothesis generating, not concluding that it's beneficial. And an editorial again said the evidence is weak to suggest that this may have a benefit. And finally, when last year investigators from Massachusetts Eye and Ear Infirmary were looking at genotypes to see how this might affect this ERG biomarker from this trial, were unable to duplicate the outcomes of showing a benefit of vitamin A. No evidence of any vision benefits, and the limitations by the Data Monitoring Committee warrant caution to conclude that vitamin A is of any benefit. There's no subsequent evidence that it's of benefit, and the reanalysis failed to show that it was any benefit. And of course, vitamin A has toxicities. In conclusion, despite the ease of accessing vitamin A around the world, and despite the potentially devastating effects of geographic atrophy from macular degeneration, or the devastating effects from retinitis pigmentosa, the evidence I've shared with you should convince you that vitamin supplementation for either of these retinal diseases may not be warranted at this time, and this is even more important to recognize because of the potential toxicities from very high doses of vitamin A. I want to thank all of my colleagues in India and all part of the Asia Pacific Academy of Ophthalmology for letting me share this with you, and I'm sorry I couldn't be there with you in person, but I look forward to joining you in person.
So we'd like to place on record our appreciation and, thanks to Dr. Bressler for, providing this talk. As usual, very lucid and clear. In the interest of time, we'll move on ahead to the next speaker, and it's our pleasure to invite Dr. Mark Penasey from the United States to talk to us about optoretinography inherited retinal diseases, and we'll take questions for both talks if required at the end.
Thank you. It's really a pleasure to be here. So in the previous talks, we heard the importance of measuring function in the macula for diseases such as AMD, as well as inherited retinal degenerations. But this is actually difficult because if you look at tests such as microperimetry, they're subjective, they're quite variable. Tests like multifocal ERG, while being objective, have a low resolution. So I'm going to talk about a new technology that provides both objective outcome measures as well as high resolution, and this is the ORG. Here are my disclosures. I'd like to acknowledge all of my co-authors, in particular Siyu Chen, who is really the brains of all of this. So if we look at individual photoreceptors using adaptive optics, you can see that there's a change in the reflectance when they're exposed to light. On the right-hand side, you can see these individual photoreceptors scintillating. And this results from a very interesting phenomenon that happens when light strikes the photoreceptor. So there are actually changes in the length of the outer segment, as well as changes in the light scattering. So initially there's a shortening of the outer segment, followed by a lengthening of the outer segment, and then a return to baseline. And so we can actually measure this, and there are different ways of doing this. One way is with AIOS2025-GP23-Age, and if you look at individual photoreceptors, you can measure the actual change in the outer segment length. And if you look at patients with diseases such as retinitis pigmentosa, you can actually see a decrease in this change as the disease progresses. Now, not all of us have adaptive optics, and so we wanted to explore a way of actually measuring these changes just using OCT, and this is going to employ an algorithm called split spectrum amplitude decorrelation optoretinography. I'll call it ORG for short. And the idea here is that if we look at the wavefront of the light going into the retina and then measure the wavefront coming out and add these together, you will get an interference pattern. Then if you flash light and the outer segment changes length, this pattern will change. And by looking at how these two waveforms are decorrelated, we can elicit a measurement. So what we deliver to the retina is an alternating stimulus of light and dark, and then we measure the reflectance of the outer segments, and below you can see how we can actually derive an optical image of these changes that matches the stimulus. And we can show that as you increase the intensity or the amount of cones that are bleached, that this signal increases in a predictable manner. This is our protocol where we do 3 scans, each 3 by 1 millimeters to measure the central macular function. And this is what a typical result or signal would look like. So we were interested in looking at patients with inherited retinal degenerations. We measured 39 IRD patients, or 55 eyes. And here's one example of a patient with a mild form of sector RP. And when you look at the OCT in this patient, you see it actually looks quite normal because their degeneration is in the periphery. And if we look at the ORG, it looks quite normal. In contrast, if we look at a more advanced patient with retinitis pigmentosa, you can see now there is outer retinal atrophy, but sparing in the fovea. Microperimetry shows a small area of sensitivity. And if you look at the ORG, this actually matches the microperimetry. Here's a second example of this phenomenon, also showing a decrease in the ORG signal, but some preserved signal centrally. This shows a compilation of all of the patients, and we can see that with these RP patients, there is a decrease in the mean ORG signal. And we can measure the repeatability of this both in healthy patients and in patients with disease and show that it is quite repeatable. Furthermore, we can correlate the ORG signal with microperimetry, and we see a nice correlation here. This is just an example of measuring this in some other patients with macular dystrophies. This is a patient with a mutation in CRX, which causes a cone dystrophy, and this patient, you can see, has a bullseye maculopathy. There's relatively mild decreases on the microperimetry, and you can see parafoveal atrophy. And when we measure the ORG, we can see a decrease in signal that correlates with the microperimetry, as well as retention of the signal centrally, where microperimetry is normal. Here's a second case, and this was a patient with a very mild case of ABCA4-related cone dystrophy. And if you look at the OCT, you can really only see very subtle changes, some thickening of the external limiting membrane, perhaps some shortening of the outer segments. And if you look at the microperimetry, there's only mild changes in the sensitivity. However, when we look at the ORG, there is actually quite a decrease in the parafoveal region. And it's interesting that when we look at the relationship of microperimetry versus the ORG, we see that cone dystrophies actually show more change in the ORG than the corresponding change in microperimetry as compared to patients with rod cone dystrophies. So this modality may be particularly useful in detecting early cone dysfunction. We've also started to look at patients with dry age-related macular degeneration, and this is an example showing two different patients, one where the imaging was performed in an area with large drusen, and you can see a decrease in the ORG signal. The second is a patient with subretinal drusenoid deposits, and once again, you can see a decrease in the signal there. This is work that remains to be completed, but early attempts show that this might be a promising way of measuring retinal function with AMD. So in conclusion, this delivers an objective and reliable measure of photoreceptor function in both normal and patients with IRDs, correlates very well with microperimetry, especially in patients with rod cone dystrophies, and it may detect early cone dysfunction loss even before microperimetry. Thank you very much.
Mark, thanks very much for that nice presentation. I was going to, as Joe's getting up, I'm going to ask you a quick question. We know that the reflectance of the photoreceptor layers is highly dependent on the angle of incidence. And I'm wondering, in real-world clinical practice, we often get scans that are obtained slightly off the center and they're slightly tilted. Are there ways that you compensate for that or address that? Because I know you showed some reproducibility data. Yeah. And along that same line, in the setting of topographical, diseases with significant topographical variability, like you showed the AMD case at the end, how do you manage that? Because it seemed to me that should potentially be an artifact.
Yeah, so I think it's a great question, and what we're actually trying to do is take advantage of that, right? So, you know, Brandon Lujan has been very interested in directional OCT, so we're actually going to try to do the ORG at multiple angles and see if you can then actually look at the relative change in reflectance at different angles and utilize that information.
Joe.
Yeah, that was great, Mark. Two quick questions. What's the relative adaptation that's optimal for this in terms of like dark adaptation? And then secondly, have you looked at recordings at different times of the day? I'm specifically interested in some of these patients and whether there might be any circadian differences in the response.
Yeah, we have not looked at the circadian response, but that is something on our to-do list and I think would be quite interesting. You know, in terms of the dark adaptation, right now it's essentially a mesopic test. We're not strictly putting the patients in the dark or adapting them or light adapting them. The stimulus itself, of course, is going to bleach, you know, some, so it's kind of hard to control that. I mean, ultimately, we do think there will be ways to actually get at a rod ORG by maybe using a red stimulus and actually doing things under dark adaptation.
Thank you, Mark. So we are at time. So we are pleased to, thanks to Anand and Paisan, we managed to stay on schedule. And so thank you all for attending this session and enjoy the rest of the APO meeting. Thank you.
Thank you again from all of us here. And thank you to Vas for steering this session, and welcome to India again.